Hello, Asif. Lovely to meet you again, and thank you so much for engaging with us in this video to discuss physician associates and the complex patient safety issues. But before we start on the questions, can you introduce yourself and your background and how you've become so interested in this issue?
Hi, Helen. Good morning. Nice to see you again. I'm Asif Qasim. I'm a cardiologist based in London. I have NHS practice at Croydon and King's College Hospital, and I do mainly interventional cardiology. And I'm also a technology entrepreneur. I've been involved in online networks for a long time, and I'm founder of the MedShr network, which is a platform that connects doctors and healthcare professionals through case discussion and peer-to-peer learning. And we connect about 2.5 million doctors and healthcare professionals globally through medical education. And in terms of PA issue, I have worked in a hospital where we've had PAs for some years, and then started to realise through 2023 that there may be some issues with the rapid expansion of PA numbers, and that's led into a whole series of issues and concerns that have been raised both by doctors and by the public, which are now coming to the fore. And so I think there's a whole range of issues that we need to work through to make sure that if PAs are working in the NHS and healthcare in the UK, that they do so in a safe way.
Well, thank you very much. And that's the purpose of today's interview, really, to explore those issues, and particularly through the patient safety lens, because there are many components to the discussions about physician associates. So, and we will put links to MedShr on the interview at the end. It's very synergistic with the work we do at Patient Safety Learning about our hub and knowledge sharing platform for patient safety. So the more we can connect people and get knowledge out there, engaged, and encourage collaboration, the better. So I think there's a great synergy there. So what we want to do today really is to explore those issues of physician associates, patient safety, to ensure that people are better informed by the issues, because there's some tensions in these conversations and some strong emotions, particularly if you follow various people on social media, and people have expressing opinions, whether they're clinicians or whether they're patients or whether they're policymakers. So having your insights would be valuable, and some reflections of, well, where do we go from here? How do we take these issues forward? But we'll start with the obvious question: what is a physician associate?
It's a good place to start. Physician associates actually have been around in a slightly different format for about 20 years in the UK as physician assistants. And the idea of this role was to have somebody who could support doctors to do routine tasks, particularly administration, perhaps low-level clinical tasks, to support doctors' workload so that doctors could focus on the more clinically relevant things, the more complex things, and release their time. So a very good principle, a good idea. And so there were physician assistants around for a while, probably several hundred across the UK by 2016-17. And at that time, the physician assistants got together and formed a faculty, the Faculty of Physician Assistants, that came under the Royal College of Physicians. And the change came around, I think, around 2017, where that organisation unilaterally decided to change their name to Physician Associates, not with any specific change in role, but just to reflect what they felt the role was. And so that's where the term physician associate comes from. And since then, a number of things have happened in terms of politically and in terms of the medical profession and so on, which have meant that the government has decided to expand physician associate numbers, partly in response to what they recognise as a medical workforce crisis. We don't have enough doctors. We don't have enough clinical care available. How do we expand the workforce and bridge that gap? So that's the principle behind it. And the reason that things have come to the fore is we've gone from having a few hundred physician associates 6 or 7 years ago to now having several thousand. And there are multiple PA schools around the country, and there are a whole different set of roles that PAs are being put into.
We'll come back and explore that kind of expansion and the implications of that, and whether that's been a particularly planned or structured approach, or whether it's kind of a bit more organic and therefore difficult to organise, manage and understand. But before we do that, Can you give me your reflections as a leading clinician and very experienced about the value from a patient safety point of view of people working in a multidisciplinary team, and just describe that with me through your own clinical practice about how different roles relate and the importance of that for patient safety?
Well, it's critical. Doctors have a specific role, but they work as part of a much bigger team. And so, for example, as a cardiologist, typically doctors work closely with nurses, they work with cardiac physiologists, radiographers, there's an administrative team, there are healthcare assistants, there are a whole series of technicians supporting that. And within that nursing and physiologist team, there are often highly specialist nurses. There are, for example, heart failure specialist nurses who then do prescribing. And so certainly for me, I supported those roles. I helped develop an integrated care service in Croydon where we integrated hospital and community, and integration of nursing and specialist nursing services was a really important part of that. One thing that we need to address is that as physician associates, it's not a separate profession, not either by a dictionary definition of what a profession is or by a medical definition, in that physician associates do a 2-year course where they learn some parts of the medical curriculum and are tested to a national exam. And as such, they come out with a qualification that recognises them as a specific occupation. It's a dependent occupation because they can only practice under the supervision of a doctor. And so they have an important role to play, but physician associates are not a separate profession or a separate discipline. So whilst they are part of the team, they are not as part of a kind of multi-professional, multidisciplinary team where if I'm in a multidisciplinary meeting with, specialist nurses, physiologists and others, they have their own separate disciplines, but have a separate body of knowledge and hence are a separate profession. So if we look at where the role of physician assistants started, which was to support doctors take over some of those routine tasks, particularly administrative, but also low-level clinical tasks, some of which can also be performed by other people, such as blood taking and cannulation can be done by nurses. Some of it can be done by phlebotomists or healthcare assistants. But the aim was we need more medical capacity in terms of that complex medical work of decision-making, planning, treatment. How do we release doctors to do that so they're not spending time doing the administrative tasks? And that's the role that physician associates should fulfill, and that's the role they were designed to do.
Thank you. You can see how complex a set of issues it is for people coming in, and particularly from a patient safety point of view, trying to understand all those different moving parts in a complex team will be quite challenging if you're not familiar with the detail. So why are physician associates in the news so much at the moment? What are the issues that are emerging, and what are the concerns that are being debated in the public domain?
So I think one of the challenges has been that the government decided that they were going to rapidly expand the number of physician associates in the NHS. So lots of PA schools have opened up. Many of them have said, this is like doing a compressed medicine course in their literature, which it isn't, and that's clear from the GMC and from NHS England. And in that rapid expansion of numbers, at present, there's a voluntary register for physician associates, but there's no formal healthcare professional or other registration, and there's no clear regulation. And so in principle, they work under the supervision of a doctor. In practice, that's not clearly defined as to how that should be. And so in that rapid expansion and with gaps in the medical workforce, PAs have been deployed in place of doctors. Mm-hmm. We've got very clear agreement across the country. It's agreed by people like the Royal College of Physicians and the GMC and by NHS England. One really core principle that PAs are not doctors and must not replace doctors. What became apparent last year was that PAs are replacing doctors, both in general practice and in hospitals. And two clear marks of that are, in hospitals, PAs are on medical rotas that doctors are on. So without being medically trained, without having a medical qualification, without being registered, without being regulated, replacing doctors on medical rotas. And in general practice, PAs were replacing general practitioners who see undifferentiated patients. So when you book in to see your doctor, whether it's for something routine or an acute problem, PAs were seeing patients in that context. And we think about 1,000 PAs were doing that, certainly at the start of this year. They're not trained to do that. Often they didn't have adequate supervision, and certainly the level of supervision is a big issue. And so the reason it's come to the fore is that because there was no national framework, no national structure, no national scope, things were being determined locally. And so when people started reporting this, issues arose. One of the challenges has been that doctors, particularly resident doctors, doctors in training, were reluctant to report issues to their employers because they worry it might affect their training. And also reluctant to report to people like the Royal College of Physicians for the same reason. You don't want to be seen as an agitator or somebody causing problems. What then happened was that when, for example, the British Medical Association did a survey of doctors, they surveyed 18,000 doctors. There's lots of interesting data out of that survey. For example, one metric was that 87% of respondents said that PAs were working beyond their scope. Now, that's a huge concern. That's thousands of doctors saying the PAs that they work with are working beyond their scope. That's a clear patient safety concern, because if you're doing something that's beyond your training, beyond your ability, and possibly not well supervised, there's a risk there. And we know there's risk in medicine. We know that there are mistakes and problems, and we work very hard through our clinical governance procedures and so on to reduce that. But certainly it would be cavalier to have people released into the workforce who we know don't have the same training as doctors, trying to do the work of doctors and with no defined scope and without supervision. And one of the challenges has been that when individual doctors and the BMA and groups like the Doctors Association raised that with the Royal Colleges and with the GMC, there was no clear response and no clear action initially.
Let's come back to that, because that's been part of the challenge of how the regulated or the regulators and the professional bodies are coordinating or responding to this, and been caught rather short on their understanding of the kind of policy implications. But the World Health Organization has annual World Patient Safety Days, and this year it was on diagnostic safety and demonstrating how challenging it can be, that sort of diagnosis, not just in primary care but in secondary care. And we're aware, we've added details of this on the hub so people can find it, of a number of coroners that have shared their concerns when they've undertaken inquests to people that have died, and have described physician associates, certainly in primary care, who have failed to identify what they would think would be relatively straightforward diagnostic assessments if you were medically trained, and the omissions have led to a lack of timely intervention and then have led to patients' deaths. So not saying that the diagnostic safety is not an issue for more broadly, but it clearly has led to some very significant patient safety concerns.
That's right, and there are a number of examples out there. There's lots of data that is emerging. For example, in Scotland, there are a significant number of serious incidents reported involving physician associates. I know that one case that has been in the news is of Emily Chesterton, a young lady who very sadly went to general practice, saw a PA and had a misdiagnosis and died. And her family have been very articulate in saying she thought she saw a GP. She didn't see a GP. A diagnosis was missing, we died, and we think that it would have been a relatively straightforward diagnosis for a GP to make routinely. GPs have a terribly difficult job. They see large numbers of patients with very short appointments, and they have this complicated mix of both very routine issues that they have to click through quickly, they have social issues they have to deal with, and they have to be able to recognise within a whole constellation of symptoms very quickly where the red flags are, where to act, and what the patterns are. I'm a cardiologist. I trained as a general physician. I would struggle in general practice, and I've been qualified for nearly 30 years. And I think one of the real problems is that if you were to put somebody into that environment with a couple of years training, first of all, they haven't seen much, so they don't have much experience. But secondly, they haven't been trained in everything. And without wordplay, they don't know what they don't know.
Yeah.
And so they may see common things and put them into a particular bucket, but they'll miss a whole series of diagnoses. And one of the problems was in the UK that the Department of Health released funding for a program called ARSS, which is an additional role funding for general practice. So they gave money to general practice to say, you can use this money to employ people in your practice, but they must not be doctors. They can be advanced care practitioners, nurses, PAs, and other people. And it specified that those clinicians should see undifferentiated patients. In other words, patients booked into the practice that haven't been triaged by anybody else, haven't been seen by anybody else. Now, for most of us, reading that, saying you're taking a PA, putting them into that environment, they're seeing undifferentiated patients, that PA should have one-on-one supervision and every patient should be reviewed by a GP. That isn't what has been happening. And there are some places where there are multiple PAs with a handful of GPs with arm's length supervision. And we know that because, yes, there are a lot of routine patients in general practice, there may not be that many mistakes, but we know there's a significant risk of serious harm. And so that level of supervision and scope is an issue. And if you think about who should be triaging patients, it should be somebody with the experience to recognize all the red flags and put people in the right groups.
And in Emily's case and in others, I mean, the one of the significant issues that struck me is that she and her family said they didn't know they weren't being seen by a doctor. And is that something that is a wider concern than that particular case, do you think? I mean, what should patients and families be expecting?
I think the name of the role is important. I think physician assistant or physician's assistant, it's pretty clear that you are assisting a physician. We have lots of different roles for doctors and titles for doctors across hospitals, and there are doctors who are called associate specialists and things like that, who are qualified doctors, often quite experienced. It's very difficult, even if you're a clinician, to fully understand, if you hadn't heard of it before, is a physician associate a doctor or not? That's the first thing. What we know is that both individual PAs and the practices that they work in are often presenting PAs as being doctors. There's evidence of this, and there's very clear evidence from specific practices. Now, the Faculty of Physician Associates and others have been clear that if you are a PA, you should introduce yourself and say, my name is Bob Smith, I'm a physician associate, I'm not a doctor, I work under the supervision of. Now, it's pretty clear that that isn't happening. Beyond that, the name has some ambiguity in it. What's made that worse in some ways is that, and we may talk about this more later, there has been some legislation passed relating to medical associate professionals that covers both physician associates and anaesthetic associates, where they will be registered by the General Medical Council. Now, the General Medical Council are very clear that doctors should have clarity and candour in what they say. There's a good medical practice, their document that guides how we should practice and behave both towards patients and other clinicians. It's very clear about this. Yet the GMC have said doctors and physician associates are both medical professionals, but only doctors are medical practitioners. Now, I'm an experienced doctor, and the nuance of that terminology, to me, is clearly ambiguous. As a member of the public, it's completely ambiguous, because if as a PA you can say that you're a medical professional, I think most of us would assume you're seeing a doctor. And that's what the GMC has specifically said this year after legislation came through.
Yeah, I'm sure my 84-year-old mum would have been quite confused by that. Before we get into looking at the policy responses and the responses of regulators, give me a little bit of an insight of how it works in hospitals, because that's a different environment with medical rotas and so forth. Are there similar concerns within hospital environments?
I think there are, but look, firstly to say there are physician assistants, now associates, who've been working for many years embedded within teams and doing a great job. For example, if you're in a surgical team, an ENT team, and you've got a physician associate who's worked with you for many years, they know the systems, they know how things work, they provide great support for the clinical team. And it does draw out some of the issues as to why in some settings people prefer having PAs. And one is that PAs don't rotate, whereas resident doctors, doctors in training, rotate.
Yeah.
Now that clearly is more a question of are there things we should fix for training for doctors, not should we have somebody not rotating who isn't a doctor? So that's one issue. So there are other environments where PAs are well supported, well supervised, clear scope. I think the challenge is that as we have a lack of doctors in hospitals, there are gaps on rotas, there are gaps in teams. PAs are being used to fill those gaps, and that's not appropriate. If we go back to that basic principle, PAs are not doctors and must not replace doctors. We know that's been happening. It's happening in trusts across the country. DA UK estimated it was happening in about 100 NHS trusts. There was a report in one of the newspapers with clear documented evidence in 30 NHS trusts that PAs were replacing doctors on rotas. It's not safe. And trusts are trying to get around that by creating what they call tiered rotas. So here's a PA rota alongside a doctor rota. The reality is that that's just getting around. That's creating semantics around the fact that PAs are on call in place of doctors. And so I think in hospitals, there's clearly a place for physician assistants, physician associates. The challenge is making sure that they work in the right way within the defined scope with the right supervision. And just on that subject of supervision, there's a proposal in the NHS long-term workforce plan that we expend to 10,000 PAs. I don't think there's any account in there for the consultant level supervision, for the time that's required to supervise those PAs, because it's not unreasonable to assume that that supervision is going to be greater than the supervision required for qualified doctors. But there's been no accounting for that in the system.
I mean, it just shows how complex workforce planning is, and the challenges in terms of the lack of capacity and how you respond to it. And one of the lessons from kind of how safety management systems work and understanding systems thinking, you have to understand what the problem is that you're trying to fix. So looking at the solution, PAs being a solution, what is the underlying problem about lack of capacity, the training rotas, whatever. If you're not looking at the whole picture, then you're only responding to one part of it, and it won't necessarily resolve the issues that are much more kind of underlying. So let's come back to responses by the GMC and the Royal Colleges, because there's been a huge discussion, debate, emotion in responding to this. So where are we in some of those discussions? And before we get your reflections of where we think we should be going, what's been bubbling under in this last year that's generated so much heat, if not light?
Yeah, the GMC have taken a line to date that they will be registering PAs from December, and that's following legislation that went through by statutory instrument and then was confirmed in the Lords in January, which was that the Medical Associate Professional Bill, that the GMC will register medical associate professionals, that includes PAs and AAs. There are lots of issues around that legislation because in the House of Lords, peers were assured that, for example, the Royal College of Physicians supports that legislation, that registration would be regulation. There was discussion in the Lords about scope, and the peers were given assurance about that, and scope isn't included. And there's clear statements in the public domain from senior members of the GMC that the plan is to register PAs, but that at present the GMC will not determine scope. In other words, they won't determine what the parameters are within which PA should practice. And if we think about scope as it has been locally determined, what that's led to is 1,000 PAs in general practice with varying and often little supervision, and multiple hospitals where PAs are replacing doctors on rotas. From Royal College's point of view, there's been varying responses from different colleges. Interestingly, often at senior level, the senior officers who are in post aligned with NHS England, Department of Health, initially with the PA rollout, and it has been members, so for example, the Royal College of Anaesthetists, Royal College of GPs, Royal College of Physicians, it's been members and fellows that have pressed and have changed the strategy. That's taken, for example, the Royal College of GPs, it's only within the last few weeks really that the Royal College of GPs have come out and said there is no role for PAs to see undifferentiated patients in general practice.
Right.
The Royal College of Anaesthetists have made similarly strong statements. The Royal College of Emergency Medicine has commented. I'm a fellow of the Royal College of Physicians. There wasn't a strong response from the senior officers last year, and so there was the second extraordinary general meeting in its 500-year history held in March this year. What was clear there was that the overwhelming majority of the fellows supported the 5 motions put forward that included looking at scope, looking at rollout, and most importantly, slowing down the rollout of PAs to make sure it was safe. And one of the things that has become clear is that although, as I said, the Faculty of Physician Associates have been part of the Royal College of Physicians for the best part of 10 years, we don't really have evidence of the safety of PAs in practice, their effectiveness, what the clinical outcomes are, what the cost effectiveness is, or formal evidence of what the impact is on training or on supervision by senior doctors. We do have clear evidence from training committees, from training groups, from the surveys that resident doctors have said PAs have had and are having an adverse impact on their training. And we're in a perverse situation where, physician assistants and physician associates were designed to release doctors to do more clinical work. We have multiple lists of reports of PAs being allowed to go to theatre to do surgery and the doctors being left to do the administrative work on the wards.
Yeah.
So, when you talk about workforce planning, I think what's happened is that the rollout of PAs has happened rapidly. If this were a medical device or a drug, it would have to have been done as a research project with medical ethics. And if you went to an ethics committee and said, we're going to take somebody with much less training, much less experience and put them in the role of a doctor, I don't think it would have got through an ethics committee. You certainly wouldn't have been able to put a consent form in front of a patient to say, instead of seeing a doctor, you're seeing this much less trained person. So if we take that level of scrutiny, I think there's severe gaps in what's happened.
So who is responsible for designing the scope? You say the GMC will undertake a role, but not to define the scope. So, rather than the 1,000 flowers bloom approach, who is going to be responsible for that, either in legislation or the view of the colleges?
This is a real problem because whilst, for example, the Royal College of Physicians is developing a scope, so is the RCGP, it's not clear who that will be presented to and who will sign it off, whether it's the GMC or somebody else. I think there's a reasonable approach to say that if doctors are responsible for PAs, which they are, if PAs are an occupation, it's a dependent occupation, then it's reasonable for doctors to say, this is the level of clinical practice of scope that I think is safe for a PA to work under my supervision. Now, in the US, there's a different approach. In many states, each PA has an individual line-by-line scope that's signed off by an individual doctor at state board level. And we haven't planned that in the UK. So at the moment, there are scope documents being developed. It's not clear. They will go out into the public domain. They will be sent to NHS England and the GMC. There's no clear process as to who accepts those, as to who they're sent to. The BMA have created a scope document, which again, I think is a reasonable thing to do as a trade union responsible for doctors. They want to make sure that doctors are protected in their practice. And that scope document is understandably relatively rigid, saying that if as a doctor, you want to protect your practice and make sure that it's safe, this is the scope that we think that PA should have. So I think right now, scope documents are being developed. It's not clear as to how they will be enacted, as to who will sign them off.
Well, fascinating, but very worrying. And certainly from a patient safety point of view, if you haven't got that clarity for the people that are actually working in healthcare, you certainly don't have that clarity as patients or family members. What's NHS England's role here on this? Is that clear?
I think there are multiple strands within NHS England. As part of the long-term workforce plan, the plan is over the next few years to go from where we are with a few thousand up to 10,000 PAs. Parts of NHS England, and there's documents to show this, clearly have a view that PAs with experience should be deemed equivalent to doctors. I find that really concerning, and most doctors and most healthcare professionals more widely find that really worrying. I don't think that having done a 2-year master's in PA studies and getting 4 or 5 years experience is the same as being a medical registrar, where you've done 5 years of medical school, 5 or 6 years in medical practice. It would be unreasonable to assume there's equivalence. Because actually, if there is, then you're saying that actually medical school and all that training is pointless, we've got all that wrong. And I don't think anybody is saying that. So I think there are real challenges within organisations like NHS England. Health Education England doesn't exist, but when it was there are clear documents from NHS England and Health Education England suggesting that there's a kind of parity between experienced PAs and doctors. That's really concerning. That's really concerning.
And I think your reflections are very helpful, because there has been debate about, well, this is just doctors being protectionist. This is not, not being not welcoming innovation and not recognizing the value that other members of a broader clinical team can provide. And what essentially you're saying is there are significant risks in scope, in level of expertise, seniority, and supervision that will undermine patient safety if not addressed. So if you had a magic wand, what would you do, Asif? Now, how would you take this forward? What do you think is needed?
That's my favourite interview question. If I had a magic wand, where would you like to be in 5 years? And now you've asked me the same thing. Look, I think it's really difficult. If we think about those physician associates, PAs who are in practice now, they've done what they think is right. They've been put in roles. Some of them have done things that their employers wanted them to do and so on that they weren't comfortable with. We need to make sure that they are appropriately looked after in terms of their scope and supervision of the jobs that they do. I really do think that in terms of expanding PA numbers, that should be stopped or certainly slowed down until it's clear what role PAs will have in clinical practice. Are they safe? Are they effective? What should they do? What are the health economics around it, both in terms of the PAs themselves, but also the supervision that they require? And this rapid expansion, from a university's point of view, there's lots of PA schools out there that are still recruiting people onto their courses. I think that is something that we need to slow down, because what's become apparent just from the data over the last year or two is that as we are now, with scope determined locally, PAs are replacing doctors. It's pretty clear that that shouldn't happen. And so just from that single point of view, we need to reset things. I think there is a role for physician assistants to support clinical practice. Part of the challenge here is that the way that things have changed rapidly, the PA courses are regarded as a master's course. So typically, PAs are being appointed at Band 7 on Agenda for Change for healthcare professionals. Now, Band 7, for reference, nurses who work with me for 10 years work through their, having got a degree as a registered nurse, then do 10 years and multiple courses. When they get to ward manager, are Band 7. Same for cardiac physiologists, where they're super experienced, they're doing scans on their own, they're reporting on their own, they're at Band 7. And we've got somebody with no medical degree, with a 2-year master's in PA studies, coming out at Band 7, often earning 50-60% more than a doctor who's fully qualified. So I think there's a real health economic issue here, and there's a positioning issue around what level of clinical practice PAs should be at, what that means in terms of their role, their remuneration, and the work that they do.
So I've got one final question and a comment. Final question: if you're a patient or family member and someone introduces themselves as a physician assistant, a physician associate, and you don't feel comfortable about that, or you're not sure about whether the input that you've received, where would you go with that? Either in a hospital or in a general practice?
That's a good question. I think there are 2 or 3 things you should consider. The first is perfectly reasonable to be seen by a PA, but it's also reasonable to ask, who is the doctor supervising and when will you discuss my case with them? If someone isn't comfortable, either because of the condition that they have or anything else like that, then it's reasonable to ask for a doctor. One challenge is clear, both in general practice and elsewhere. Often, you might have to wait longer to see a doctor, and that might be on the same day or a different day, for example, in general practice. There are campaigns out there saying ask for a doctor. I think that's not unreasonable, but likewise, perfectly reasonable to be seen by a PA, as long as you know that they're well supervised and that you're not being seen in isolation.
Yeah, thank you for that. And my comment, or well, it's a question to yourself actually, which is, this has been a fascinating interview. I thought I was fairly familiar with many of the issues, but you've really helped me understand the complexity and the depth of these issues, and why it's such an important issue, from kind of people's personal professional responsibility, but also from a patient safety point of view, that why we address this. Will you no doubt you'll be keeping a very close eye and contributing to debate on it. Will you come back in a while and reflect on progress, and share your insights for a kind of wider audience?
Of course, happy to do so. And look, I think it's easy to get stuck in talking about the minutiae of medical training and these things. I think when it comes down to it, the reason people practice medicine is because they want to do the best for their patients. It's about having better quality of life. You know, it's easy to raise flags about saving lives. Most of what we do is about making patients' lives better and doing that in a safe way. Doctors practice in a way that is constantly reflective about that, both through governance process and personally. And so the issues around physician associates, they're not personal to the PAs. It's more about making sure that we get the systems, the structures, and the way that we practice right to make sure that patients get the best care they can.
Well, thank you. Thank you for your commitment for doing that, and thank you for your time today for the interview. It's been wonderful, and we'll see you again. Thank you, Asif.
Thanks, Helen. Nice to see you.